UCC, Valerie Cabe. I have one more announcement that I wanted to make to the group that are on the call at this time. We had said that we would offer CEs for this, for attending this webinar. We may or may not be able to offer those. We've came up with a problem in offering them, and we just wanted to disclose that at the beginning of the call, and we will be notifying you afterwards what the disposition of that is for everyone. So thanks for your patience till we get that figured out.
Okay, and one last announcement. Our second OB Hemorrhage Toolkit webinar will be May 27th. Unfortunately, that registration is full. However, if you would like to review the contents of the first webinar, that is also available on cmqcc.org on the page of the OB Hemorrhage Toolkit download. If you have any questions regarding any of that, feel free to email me at jvasher@stanford.edu or vkate@stanford.edu. So I think we'll get started. We're very excited and pleased to have Dr. Holli Mason with us today. Dr. Mason is currently the Associate Medical Director of Transfusion Medicine, as well as Medical Director of Core and Associated Laboratories at Cedars-Sinai Medical Center. She holds academic appointments at both Cedars-Sinai and UCLA at the rank of Associate Professor. She is the current President of the California Blood Bank Society. She participated in both the original and version 2.0 of the OB Hemorrhage Toolkit development for CMQCC as a member of our expert panel. Prior to her current position, she was the Medical Director of Transfusion Medicine and Serology at Harbor UCLA Medical Center for 11 years. She graduated medical school at the Medical College of Virginia, VCU, and did her anatomic and clinical pathology training at Cedars-Sinai with a fellowship in surgical pathology at UCLA and a transfusion medicine fellowship back at Cedars-Sinai. So you can see we're certainly going to be well taught today by Dr. Mason. So with that, I'm going to turn over the remaining of the time to Dr. Mason.
Thank you, Valerie. I appreciate you guys asking me to be here today. I have to say that it was, I think it was very wise of the obstetric leadership that put together this group to involve some of the ancillary areas, including blood bank, lab, and anesthesia, and including us in the toolkit task force and the expert opinion. So as they engaged us in blood bank and lab, we wanted to talk to you a little bit today about how to do that on your own in your own local areas, engaging your blood bank so that you can have a more robust obstetric hemorrhage toolkit. I'm sure you've all been out to the CMQCC website and taken a look at that. We're pretty proud of that. So just a little bit about the different types of hospitals. I know you guys all come from a variety of different backgrounds. Some of you are at large academic medical centers such as Cedars or UCLA, UCSF, some of the Kaisers. And most of these hospitals have dedicated full-time transfusion medicine specialists like myself. And of course, that's a great resource, and I hope you all know to take advantage of that. We're actually sitting here waiting to be asked questions, and we really love to get engaged and see what we can do to in our little sliver of what we do to make your life a little bit better. Most of these professionals are fellowship trained in transfusion medicine. And we actively engage on a daily basis with our clinical counterparts all over the hospital. Then there's the mid-sized hospitals, generally non-academic. They often have a clinical pathologist that oversees the whole lab, chemistry, hematology, coag. They may have some in-depth transfusion medicine knowledge depending on their training background, but they may have more of a focus in other areas such as hematology is most common, or chemistry. And then there's those small rural community hospitals and even small inner city hospitals where there may have one or two pathologists that run the entire lab. generally speaking, these people are much more focused on just general laboratory medical director duties and surgical pathology primarily, and very little with transfusion medicine. So it might be more of a challenge if you're in that hospital setting to get engagement, but I'm going to see if I can help you find your niche and how to do that. So like I said, if your hospital has a dedicated transfusion medicine specialist, of course, go directly to that person and discuss with them what you'd like to do and that you would like to see, if we already have a transfusion, massive transfusion protocol in place, say for trauma or some of the other areas, if obstetrics can be a part of that, or if there needs to be any modifications for your area, or if one needs to be developed from scratch. Hospitals with just a general clinical pathologist, it's probably good to start talking with that person, but you might have a little more success if you're working more with a manager or a supervisor of the blood bank, because they'll have more of the in-depth knowledge of the nuts and bolts of how to get a massive transfusion protocol up and running. And then if you're in one of those areas where you don't really have a designated blood banker, or that the medical director of the lab is not a transfusion medicine specialist, working through the blood bank, there's the possibility of getting some support from the blood vendors. So there's Red Cross and a variety of other vendors, which I'll get into a little bit later, that do supply blood to the hospitals, but they supply a lot more than that. These blood centers are generally run by medical directors who have a similar background and training to what I have with training in pathology and a specialist in transfusion medicine. So they actually act as adjunctive support to smaller hospitals. So they're like the consult person to the pathologist who's running the blood bank, who's not an expert in that area, and they often call upon them, say if they have an unusual transfusion reaction like trolley. They might contact their vendor for blood and ask them if they can help weigh in on how to handle it, what to do next. Occasionally, the doctor who is at the outside vendor facility even runs transfusion committees. So depending on your hospital, they might already be very active. So these are the blood centers of California. I apologize that these are so light on this. If you do have access to this slide, these are all clickable links. So I decided to leave them the way they are. And for some reason, I couldn't get the font to come up a little darker. Sorry about that. But if you would like to get this slide and click on a link that is a supplier for your area, then you'll be able to get right to the people that you might need to talk to. I would say please don't leave your blood bank out of the loop, because that will only alienate them, and that's probably not your goal. You want to work with them. So if you're working with your either the doctor in the blood bank or the supervisor, manager, that they can help you connect to the right people at the vendor to see if there's some support that can be lent to as far as developing a massive transfusion protocol, stocking, and some of the other things that we'll talk about shortly. Let's see. Okay, so once you have identified the person that you need to talk to in the blood bank or with an outside vendor, making a plan is the next goal. So I always like to say a goal without a plan is just a wish. So communication is definitely key. Like I said, don't leave the blood bank out of the loop if you're going to be working with an outside vendor. Make sure that they're also definitely part of that. Making a plan while everything is calm before you've had an emergency or reacting to a bad outcome is really the goal here. Discuss it and get agreement on all procedures. Sometimes different specialties have a different idea what they think is the best way to handle things, so getting that agreement before there's an emergency is a really great idea. The CMQCC Hemorrhage Toolkit 2.0 is a really great start. It's really step-by-step instructions on how to put things together and exactly what we recommend for a massive transfusion protocol. And then one of the things and we'll talk about this a little bit later with the stocking, is consider thawing plasma ahead if it's feasible. So that's really going to depend on your hospital and how much blood you use, how much plasma you use. But we found that that's a really helpful tactic to provide quick emergency blood. And then, there's, in the blood bank world, there's a lot of talk about should we have A's thawed out instead of ABs, since ABs are relatively rare. And then our goal, and what you'll see again and again as you look through the hemorrhage toolkit, is to get plasma delivery started as soon as possible. So stemming that coagulopathy that develops in the setting of a peripartum hemorrhage is really important, and this is very useful to do that. So getting started, I always hate the idea of cookbook medicine, but sometimes being standardized and kind of not reinventing the wheel, seeing how other people have done it, is a pretty good idea. So to get started, just looking at your own service, how many massive transfusions are typical? It's usually pretty rare. There's usually not more than a few a year in most hospitals. Even ones with as large a delivery rate as we have here. Identifying champions in the critical areas is also a good starting point. You may want to have kind of on standby people from trauma, surgery, other areas of the OR, and the ED, as well as your obstetricians, to be helpful in the process. MD participation is definitely key, but involvements of your RNs and other ancillary personnel is smart, because they're the ones who are actually doing the work, but the MDs are the ones who kind of drive things. Review the literature. We have an e-network forum at our California Blood Bank Society website where we have all kinds of protocols, and we've done a lot of discussion on different protocols for massive transfusion and what is recommended. And I'm sure most of your blood bank professionals will be aware of that. So in looking at setting up a massive transfusion protocol in your own hospital, some of the things to think about are what's your facility like? What kind of stocking are you going to want to have as far as what blood products having on hand? What about notification? Will you call the blood bank? Will there be a text page? Some hospitals do it that way, where everybody in a code situation gets a text on exactly what's going on. Perhaps an overhead page would work best. So it's really going to depend on your facility and what works best. Distance, when you look at the facility question, it might be the key factor. So how far away from the blood bank is your labor and delivery or your OR? Is there an area in the hospital for a stat lab, or is there any capability of a stat lab for quick turnaround times of critical laboratories, so hemoglobin and hematocrit and your coags? And then logistics of stocking and maintaining and monitoring remote refrigerators and kiosks are something that, as a blood banker, that's one thing I always think of. We are very, very highly regulated in the blood bank, as I'm sure you're aware, and one of our regulations is that blood is always kept in a monitored refrigerator with preset alarms that will alarm before the refrigerator goes out of range, so that the blood isn't wasted. Once that refrigerator goes out of range, we have to actually throw away the blood, even if we're relatively sure from a scientific point of view that it's fine. So that really kind of puts us in a interesting situation when we're sending coolers out to the floor. So we actually validate these coolers, and that this is the usual way we handle having a large amount of blood in a location that's remote from the blood bank. And the coolers can be validated by the blood bank for, we cool them down on the inside and then just test them periodically to see how long it takes for them to go out of range. Once we've validated that, we can send those out, but getting them back in time is always an interesting thing that can be problematic for us. Then there are several different types of cooler. The cooler you see there on your screen is just the regular beer cooler that you would take to the beach, and that's actually what we use here. So it doesn't have to be anything very fancy as long as it can be validated. There are some really nice packs where you have the sides are actually made of freezer ice that are frozen in sheets, and you slide it into a wire frame, and that actually makes up your cooler. Those are actually pretty quick and easy to get mobilized. A little more expensive, though. Then turning to stock, you know, I put here O-negative only because of course, your hospital is also servicing other patients. This is not only obstetrics that might have a massive hemorrhage. So if you're folding this into the massive transfusion protocol that also is going to be servicing the rest of the hospital or the ED, you have to take into consideration, are you going to have O-positive blood available for males? And if you do that and you have it stored in a remote area, say a monitored refrigerator in the OR or in the ED, how will you communicate to the staff who will be taking that uncross-matched blood that one is O-positive and one is O-negative? So one of the things that I think it's USC did was they put pink shelves had O-negative on it and blue shelves had O-positive. So if you had a woman, you just took from the pink shelf. So there's little things you can do like that. In an emergency, you don't want to have people sit and figure things out. You want to make it pretty quick and easy. If this is sent out from the blood bank, we can dictate what's sent out, so that kind of takes that guesswork out of it. But depending on how far you are away and how many people you have in your blood bank, that might not be an option of having somebody running from the blood bank to where you are. If there's nobody left in the blood bank to set up the next round, that could be a challenge. So then turning to plasma and the AB, AB plasma lacks the antibodies to the anti-A and the anti-B antibody, so it's the one that we usually save for babies. And we also use it for situations where we don't know what the blood type is. Here at Cedars, we have enough use of the plasma that we actually keep ABs thawed at all times. That's probably not practical at most places. So most places, or I would say a lot of places, opt to have A units pre-thawed and kept liquid so that we can mobilize them quickly. The A's, of course, are going to lack anti-A, and most patients are either group O or group A. A very small percentage of patients will be group B. A plasma will have anti-B in it, so this could be a risk to that small number of people who are B blood type. However, you can receive a small amount of incompatible plasma without any clinical harm. That's one of the reasons that we ask for a specimen pretty quickly, because if we're going to do that, we can't do that for very long. If you're going to send out coolers, one of the things to think about is what will be the ratio. I'll tell you how we do it at Cedars in a little bit, but generally we're looking at a 1-to-1 ratio, and usually about 6 at a time. Are you going to have platelets available with this, and are you going to have cryoprecipitate available? If you decide that having a remote refrigerator works best at your hospital, restocking them could be an issue to consider for the blood bank. What several hospitals have done is have an alarmed refrigerator so that when you open it in the ED or in the labor delivery area, we know that it's been opened and we know to go check and see if we need to restock that refrigerator. And also platelets. Do you transfuse enough at your hospital to keep platelets in the hospital? They only have a shelf life of 5 days. So some hospitals don't go through them often enough to even have them on standby. This is actually where working with one of the vendors for your hospital might be very advantageous. Often they have depots nearby your hospital that can send platelets to anywhere in the region as they're needed. And you can find out from them, how long would it take if we gave you a heads up of, say, half an hour to an hour, could you get us some platelets by then? And you can work with them on how you can make that process go a little bit faster. So how we do it at Cedars, I'll take you through the roles of the different individuals on the team. So the role of the physician, either your obstetrician, surgeon, or anesthesiologist, he or she initiates the verbal order for the massive transfusion event protocol. and documents the use of uncross-matched blood if necessary. So we always send a form with our uncross-matched blood for the doctor to sign saying that this is an emergency. And he or she is the one who terminates the massive transfusion event protocol. So they start it and they end it. They may need some prompting by the nurse to say, are we done with the massive transfusion, but it's really up to them to say, okay, we're finished. This is what our uncross-matched transfusion request looks like. It has our phone number right at the top. It has, as you can see, 6 units of O-negative blood on there, and those are the unit numbers. And if you look at the bottom, what we are asking the doctor to sign is a statement that I believe the patient requires emergency transfusion and cannot wait for routine compatibility testing. I understand transfusion medicine personnel will perform routine compatibility testing as soon as possible and will report any incompatible that they find to me immediately. So one thing I wanted to make sure to impress upon you is that as soon as we have a specimen, even if the blood is already out of the blood bank and you're using it and you're hanging it, we're busy cross-matching it as we go. So very often, by the time you've got that first unit in, the other 5 have already been cross-matched. So you can kind of rest assured that you're not kind of flying in the dark and you're not flying blind. The other thing is that of all comers who come to the hospital, about 98% will not have any red cell antibodies. So their cross-matches will always be compatible as long as they're lacking those antibodies. So that's only 2% that might have incompatible cross-matches. Of those 2%, the risks are pretty low that anything bad is going to happen. Usually it's just a higher than average turnover of those red blood cells, but not intravascular hemolysis like you would see with an ABO incompatibility. So it's really a fairly low-risk thing to give uncross-matched blood if it's needed. Okay, then the role of the nurse is to call the blood bank. The doctor has just said, I'm activating the massive transfusion protocol. The nurse calls the blood bank and says, this is Nurse Holly, I'm activating the massive transfusion protocol. And then she lets the blood bank know the patient's name, medical record, gender, and age if known. That helps the blood bank decide if we're going to give O positive or O negative. So since you guys are OB, it's always going to be female, and you'll always get the O negative. And then the specific location where the patient is so that we know exactly where to send it. And in our blood bank, we actually have runners that take the cooler and run directly to you. But we also have uncross-matched blood at the site where you are, so you can get started with a couple units of uncross-matched blood from your refrigerator while we get the trauma pack over to you. The charge nurse designates one single person as the communicator with the blood bank. I think this is very important. In the past, we've really been plagued with dozens of calls in an emergency to the blood bank asking to add on another FFP, take off a cryo, we need 2 more red cells, no, cancel the order for red cells, but from different people. So it really gets to be very confusing. It's like, okay, well, how many red cells do we need at this point, how many of this and how many of that? So having one single person let us know that it's time for the next round of massive transfusion pack, that is really cuts down on confusion and mistakes. If needed, samples should be sent at this point, and the charge nurse is in charge of making sure that that happens. We require 2 separate samples at Cedars if the woman is non-group O. If she's group O, then we will continue giving O blood because that's going to be safe even if we've made a mistake. But if she's a group A, AB, or B, we're going to want to confirm that that's really true before we send out type specific, because an ABO incompatible will actually kill somebody. So and within 1 unit. So that to us that is very, very important. The uncross-matched O negative, very little risk, but the ABO mismatched, very, very high risk. So we're very strict on that one. The charge nurse also is the person who alerts the blood bank when each new cooler is required, and alerts the blood bank when the physician has terminated the massive transfusion event order. So what do you get at Cedars when you activate the MTE protocol? You get a cooler with 6 O negative units, and this is what our cooler looks like. There's 2 inserts here. One of them is O negative and one's O positive because we do other traumas here too. but you would get the insert with the O negative, and as you can see, that those fit perfectly in the cooler. On the other side of the cooler, you would have your 6 units of plasma. Now, if we know what the patient's plasma, our blood type is, we will give type-specific plasma because we want to conserve our ABs. But if we haven't gotten a specimen from you at the point where a massive transfusion is called, we'll give you some AB plasma until we get that sample and get a type so that we can switch over to type-specific on the plasma. We also give a unit of platelets with each cooler. The platelets must stay at room temperature. If they get cold, they do not work anymore. So we put them in a paper bag with a big fluorescent sticker that says do not refrigerate so that that doesn't get put in the cooler. And we also, on every other round of the massive transfusion cooler, we will send a pool of cryo as well. The blood bank's role in all this is deliver the coolers with the 6 units of red cells and 6 units of plasma and the 1 unit of platelets. We keep ahead, and by the way, we usually are at the bedside within about 5 to 10 minutes, usually closer to 5 minutes. We keep ahead 6 units. Basically, every time a massive transfusion cooler goes out the door, we restock immediately. We don't wait to find out if you're going to need another one. We never know if we're going to have a different patient that's going to need it. So we always have our next batch ready to go. Let's see. We ensure that the cross-match sample is processed ASAP after the O blood is released. If we find out that the patient has an antibody, we will be letting you know to watch for maybe some delayed hemolysis or quicker than normal turnover of red cells. It's usually not going to happen for the next week or so, or maybe 2 weeks. So it's not something that in the heat of the moment is going to be much of an issue. They also notify the blood bank medical director after the second cooler is sent out, so we know that we've got something kind of big going on and we'll keep our eye open. And then if needed, I will contact the team or someone on the team and assist with ongoing transfusion needs as warranted. So you know, any advice I can give them, anything that extra can be done. And then I can communicate that back to the blood bank staff and make sure that they're on the same page. I think we talked a little bit about the thawed plasma. If you're in a situation where having pre-thawed plasma really isn't viable, you just really don't transfuse blood or plasma very much at all in your hospital, if you have to thaw it as you go, the thaw time is approximately 45 minutes. So in that situation, it's good to know that that's the situation with your blood bank, so you would want to make sure to be thinking ahead a little bit, and if there's even the possibility that you're going to need it, to tell them to go ahead and start thawing. Worst case scenario, you waste some plasma. That's not the end of the world. I would rather have it be available when you need it than worry too much about wastage. So it's just kind of a patient safety thing. In most situations, though, some plasma is probably, having a couple units of plasma thawed already. You can, and we could talk to blood bankers about this too. Once you thaw it out, if you relabel it to thawed instead of fresh frozen plasma, you can keep it for 5 days. So that's what we do here at Cedars. We have 5-day plasma. And if we haven't used that plasma in the first 4 days, we actually issue it to anybody who needs plasma for any other reason around the hospital and thaw out a new batch. Honestly, here it doesn't usually last that long, but it's a good strategy. So if you haven't given us a sample before initiating a massive transfusion, we'll use the AB plasma. But this is kind of a tricky thing because it could exhaust our supply of AB, and that could compromise the safety of another patient later on, especially if you have an AB patient. They will have to have AB plasma. Some pitfalls with the massive transfusion protocol is the sample. That's for us in the blood bank, that's probably one of the biggest headaches. What we usually hear is, I thought the ED sent it when the woman first presented. I thought it was already down there, or I don't know why I need to send you a second specimen, you already got one. Another thing to understand about the blood bank is we also use a couple drops with every single cross-match. So we may ask for more blood just because we need more to keep doing the cross-matches, not because we're checking the blood type. Other pitfalls are improper and overactivation. I remember when we first started the massive transfusion protocol for OB, I had somebody call me and say that they would like to activate the massive transfusion protocol at 4 p.m. today, and it was about 10 in the morning. I thought, well, okay, how do you know you're going to have an emergency at 4 p.m.? And what it was is she had a placenta previa, and she was going to do a C-section, and really what she wanted was a previa pack, which is a little bit different. That's 2 units of red cells at the bedside in a cooler, just in case there's bleeding when the baby's delivered, as I'm sure you all are very well aware. Poor communication was a big pitfall when we first started, so designating that one single person to communicate with the blood bank was a huge help for us. And then wastage of blood products. One of the things that we found when we first rolled it out is that they would keep asking for the massive transfusion pack until they didn't need it anymore. So then what we usually ended up was at the end of the event having a full cooler in the room. That's fine as long as the cooler comes back to us, but often the cooler would sit there because maybe we might need it, we're not sure, and before you know it, the cooler's expired and we would have to throw away everything that was in the cooler, which is kind of a shame. So as long as you can send that cooler back to the blood bank once the event is over, then blood can be issued as it usually is, and there's really no need to hang on to that. So how to avoid the pitfalls, what we found is intensive in-services with all the staff, including the MDs, the house staff, and nursing. This is definitely where that MD champion is key and nursing support is smart. Post-activation review of every massive transfusion protocol. So we did these mini debriefs once a week. We would take all of the cases that had happened over the week, and these weren't just OB, otherwise we wouldn't have anything to talk about most weeks. These are mostly traumas. But we would include all the players that were involved in it as much as possible, and especially the MD. We've designated a note taker to capture what went well and what needed improvement. And then we conducted mini RCAs as needed for incidents that we thought had potential for harm, like us not getting a specimen. And an excessive amount of A plasma being transfused before we found out that the patient was a B, for example. Okay, so that is my presentation. I wanted to make it relatively short to give people plenty of time to ask questions. I guess I'll turn the screen back over to Julie so that I can see your questions. Prior to starting the conference, though, Julie did send me some email questions. So if you'd like, we can start with the questions that were emailed to me, and I can answer those. Does that sound good?
That would be great. That sounds great.
Okay. All right. So I won't be able to see their questions unless I transfer over to you, I think, with my screen.
Okay.
How do I do that?
I will make myself the presenter.
Okay, you can do that.
Okay.
I'm very technologically handicapped. Sorry about that. Okay, so the first question that was asked was, one of our group members would like to know what is the recommended time in minutes to get blood from the blood bank to patient in the case of severe hemorrhage. In essence, how long is too long? So my response to that would be that uncross-matched O-negative blood should be almost instantly available. If we have it in the blood bank, uncross-matched blood means it hasn't been cross-matched yet, so we can just hand that out pretty much. The caveat to that is how far is the blood bank from the patient, so how much time is it going to physically take to get from the blood bank to the patient. So that's why I talked a lot about remote storage and coolers and things like that, having it closer to you. The blood bank does need some basic information on the patient for release. So we need an uncross-matched form with the name, medical record number, birth date, some identifying, at least 2 identifying characteristics. In our highly regulated world of blood banking, we absolutely must be able to track exactly where every unit went from cradle to grave. And if we're not able to do that, if an FDA inspector happened to walk in the middle of one of these and we were just handing blood out and we didn't have any information, the blood bank could actually get shut down. So that would not help anybody. With the massive transfusion protocol, generally a kit is put together and pre-issued at the beginning of each shift. That's how we do it here. So our blood bank techs do that read back of all the unit numbers to each other, and then we have it designated on a special shelf so that we know when it gets activated. It's already been pre-issued. We've already gone through all the read back things. We can just pop those into the cooler and run with it. So we're usually at the bedside within about 5 minutes. Also, we're retrospectively cross-matching those, so sometimes by the time you're hanging, the units are already cross-matched. The next question is, can she comment on CMV prophylaxis in CMV seronegative pregnant women who require blood transfusion? In general, it's a good idea to use CMV-safe blood for CMV-negative pregnant women. We consider leuko-reduced blood CMV-safe, and here at Cedars, we only give filtered leuko-reduced blood. So in an emergency, we know that everything that we have is going to be okay. And so we don't have to rely on, has this person been tested for CMV, has the blood been tested for CMV, we consider all of it CMV safe. If you're not using 100% leuko-reduced blood, some hospitals will segregate some CMV negative pre-tested blood on a certain shelf so that they can go there first. Otherwise, it can be kind of challenging to identify those units fairly quickly. Let's see, next, would be helpful to review an update on the risk of infection related to blood or blood product transfusion. The viral risk actually is quite low now. We are doing better than we ever have in the history of transfusion. It's about 1 in 2 million cases of HIV getting past testing. It's actually now would make major headline news if anybody in the United States got HIV from a red cell or a blood transfusion. Hepatitis C virus is the same. We do PCR for both of those. Hepatitis B recently got added to the PCR testing, as has West Nile virus. There's a little bit higher risk for hepatitis B, but since most people don't donate while they're in an acute infection because they are obviously very sick then and it resolves generally, the risk is actually probably lower than that. The risk of bacterial contamination, especially for platelets, has stayed fairly constant. It's always been a pretty low level, but that's probably the biggest risk at this point in time for infection. And we now culture every single platelet that is transfused, so we're surveilling for that constantly. The next question was risk diagnosis and management of TRALI. This is actually a whole lecture in and of itself, so I'm just going to give you the synopsis here. The risk is about 1 in 5,000. This is something you really can't predict at all. You don't know who is going to have that reaction. The most common and likely mechanism is donor anti-HLA or anti-neutrophil cognate to patient-specific proteins. So if the patient has the HLA antigen that the donor has an antibody to, it can cause TRALI. The management is supportive. It may require intubation. The only caution that I would give is that the pulmonary edema in TRALI cases is not due to fluid overload, but it mimics a fluid overload situation. So aggressive diuresis can be risky. You can end up bottoming out pressures, and people have died from aggressive diuresis with TRALI. Sometimes it's a little of both, so if you need to diurese, just do it gently. Any pearls for how to manage a patient who has a difficult cross-match? My best advice here is give us a sample as early as possible so we can get the whole workup done and identify rare units if we need to. We recently here had a patient with sickle cell disease and multiple very complex antibodies. She was pregnant and in the hospital here, and we did her workup very early in the pregnancy and then kept following her as we went, and the whole time she was pregnant we had units standing by in case we needed them, and when she did deliver we had those units. We can always confirm with a new sample if it's expired, but the fact that we've done the workup and we know that this is the safest blood for that patient, that's really the best way to go, just as early as possible so that we get as much time as we need. In her case, it took days to identify the antibodies because they were so rare, and then it took more days to find compatible units for her. So depending on how complex it is, it can be very, very time-consuming. Any best practice guides in what to order to transfuse products during massive transfusion? All the red cells first, followed by FFP and platelets, alternating products, doesn't matter. So as I said earlier, we try to do a 1-to-1 ratio once we've gotten to the massive transfusion phase. Usually you've given a couple of units of red cells by the time you get there. But once you activate the massive transfusion protocol, our goal is really to get the plasma in as early as possible to head off coagulopathy, which is very common in peripartum hemorrhage. So I would say giving them kind of equally a red cell and a plasma, a red cell and a plasma. If you've got 2 lines going in, doing them both at once is probably a good idea. The goal here is just to get the plasma in as early as possible. We can also give cryoprecipitate and platelets. So what we do is the cryo every 2 rounds and the platelets for every round. Okay, so that was all the questions on the email. So let's look at, I have, looks like 2 questions here. Can you speak to using factor 7 or tranexamic acid? So factor 7 is fairly controversial. There was a lot of use of factor 7 in the military and in the trauma settings. I have a lot of experience, especially in my time at Harbor, in using it in trauma situations with very good results. It is contraindicated for people with cardiovascular disease because plaques in the arterial walls actually have tissue factor that's expressed on the outside, unlike normal endothelium. And the thought is that you could form a really serious clot, especially in a coronary artery. That's usually not an issue for pregnant women, but what is an issue for pregnant women is that they are in a hypercoagulable state just by virtue of being pregnant. So there's a lot of concern about adding to that, and could you end up having a woman have a stroke or some serious clotting event because of factor 7. Factor 7 has been used. To my knowledge, there have not been any serious reported complications. I think the concern is mostly theoretic. The other thing that makes factor 7 a little more controversial is the cost. It's about $10,000 a dose, and the half-life is about 2 hours. So it doesn't last very long. Sorry, I have my other line ringing. We'll just let that go. So I think sometimes when they say it's not the money, it is the money. But I would be a little leery of using factor 7 on pregnant women. And in fact, we speak to it in the hemorrhage toolkit as something that might be considered, but we don't advise it and we don't advocate. Tranexamic acid, I am not very familiar with its use in the pregnant population. I know that we use it with our cardiac patients in reversing or at the end of bypass, and we use it a lot in our orthopedic patients, but I don't have any experience in the obstetric setting, so I'm probably not the best person to ask about that. Sorry about that.
This is Valerie. There was a question that came up about that last week with one of the mentor teams.
Okay.
And there is a new little section in the new toolkit. It's in the article that's on page 106 of the toolkit entitled Blood Product Replacement for Obstetric Hemorrhage. And I'll just quote it, it's just a couple sentences. Tranexamic acid is a lysine analog and anti-fibrinolytic agent, which has been shown to modestly reduce blood loss in multiple studies of surgical patients. The hemostatic process is reliant on a combination of coagulation factors and a tight net of fibrin covering the damaged areas. There are limited studies in obstetrical patients to demonstrate efficacy and safety. Preliminary data suggest only modest benefit, and we recommend waiting for results of a large multi-center trial which is being undertaken in Europe, the Women Trial, which is designed to evaluate usage in obstetric patients. And there are a couple of references attached to that particular paragraph, so share that with everybody here.
That's really great. I think that'll be helpful when that study is published. Yeah, the mechanism of how tranexamic acid works is it basically enhances the clotting cascade, because at the end of the clotting, what you have is remodeling and breaking apart of the clot, because you don't want too much clot. But if you're not clotting well enough, this actually inhibits that process a little bit so that the clot holds a little bit better. And then factor 7, how that works is it attaches to tissue factor, which is exposed on disrupted endothelium, and that attaches to platelets and makes a nice little plug right there. One of the things that is a little bit dangerous about factor 7 is it forms what they call a superclot. And even with TPA, it's difficult to lyse that clot. So if you did get into a situation where you had an embolic stroke or a thrombotic stroke, it would be very, very difficult to treat. So that's one of the theoretic risks and why it's a little controversial. Okay, the next question is from Judith Bliss. We have 2,000 deliveries a year. We have 2 to 4 units O-neg in the hospital blood bank total. We don't give transfusions very often. Otherwise, blood comes from the regional blood center. What would be the recommended amount of blood in the hospital? So that's a very small amount of blood. Generally speaking, most hospitals like to keep on hand a blood supply that will carry them for about a week. So if you give so few blood transfusions that you wouldn't use even as much as what would be in one transfusion pack in a week, that could be a challenge. So I think that would be a situation where working with the regional blood center and talking to them about how close their depot is, possibly increasing your stocking level just a little bit, not enough, you got to watch your wastage, but having enough so that you could at least get started on a massive transfusion protocol while they brought in more. So if they're 20 minutes away and they can get emergency blood to you within 20 minutes, if you have enough for the first round of massive transfusion resuscitation, so that you can get that fairly instantly and have that delivered to you, and probably a few rounds worth, that's probably a good way to handle it. If they're not able to get it to you that fast, I think that you might want to consider upping that stock just a little bit, because that's a situation where if you get in a massive transfusion protocol situation, you may not be able to keep up very, very easily.
Are there any other questions? If anybody has any questions, we have a few more minutes. You can type them in the chat box and we can address them.
I think it's probably going to be the most challenging for those of you at the smaller hospitals where transfusions aren't being done very often. I think this situation in the last question is probably the biggest challenge. How do you have that on hand? So I'm hoping that your regional blood center will be able to help you with at least having a standby depot that they can mobilize quickly.
Great. Is that what the first step for these smaller hospitals then would be to make sure that they have that, establish that relationship and know what they have and know how fast they can get it? Is that what the first step? Okay.
Yeah. Okay. Judith just posted another question. Are there guidelines for amount of blood within an hour per number of deliveries? We're not a trauma center, so it seems not enough based on what we give normally. I don't think there's a guideline for amount of blood within an hour per number of deliveries. I don't think that's ever been looked at in quite that way. I think I would have to say that even though we know that it's a rare event, we know these happen, and if you're not prepared for it, it's probably going to be a bad situation if you have somebody who is just hemorrhaging like crazy, and you only have 2 units of blood to give her. So one thing I would probably advise, and I think that's covered also in some aspect of the toolkit, is in the leading up to stage 0 and stage 1, if it looks like this is a high-risk pregnancy, probably this isn't the best hospital for that delivery to happen. It should probably go to a hospital with a higher level of acuity. But that's not always predictable. We're looking at the number of women who have a bleed greater than a liter, and that's about 4 to 5%. And in that group, about a third of them had no risk factors at all. So it doesn't mean that these smaller places won't ever see one of these bad situations, even if they're keeping up good surveillance for assessing people ahead of time.
Great. Are there any additional questions? We could take a couple more questions.
Holly, this is Valerie. I had one question, and not being a clinician, I hope it's not one of those really dumb questions.
There's no dumb question.
On your slides, when you showed the form that the doctor signed at the bottom for the massive transfusion code, it had the little stickers on the left with the blood units numbers on them. It looked like there were some initials along there. Is that something that's real common, that if you're doing the protocol that something gets initialed on that?
Yeah, I think I have to look back.
I was curious about it. Maybe nobody else was, but I was curious.
I think that's part of the pre-issue protocol we have. So at the beginning of each shift, 2 CLSs sit down together with the massive transfusion box, and they go through and do the numbers read back, so that we know what we say we're issuing is what we're really issuing, and that they're probably initialing those as they go through them.
Okay. I was curious about that. I didn't know if that was part of that. It got initialed if it got used in the protocol, or
it's probably the read back, because that's one of the ways that we save time. When I was first doing this at Harvard, our first massive transfusion protocol that we designed, when the person from the emergency department or labor and delivery came to our window, we would have them go through really quickly and read back all 6, and then we would send it out. But that was taking too much time. So what we wanted to do is have that part already done. So we just took 2 people who are competent and licensed in the blood bank, did that read back to each other there, and then put it back in the refrigerator. So then when they came from labor and delivery and said, I need the massive transfusion box, they would just give us the patient's information, and we'd hand them the box, and then off they'd go.
Okay. Great, thank you.
Dr. Mason, looks like a couple more questions.
Yes, so I see that from the same person, has the collaborative thought of coming up with guidelines for amount of blood, and it would be helpful to have something that says we should have, say, 6 units of O neg available, as well as other types, NFFP platelets within an hour or something like that to the blood bank. They focus almost exclusive on avoiding waste. So that is a very good point. I think that our recommendation is that having the 6 and 6 on site is, if you're doing deliveries, is probably a good idea. I think it would be smart. Being able to get platelets in a reasonable amount of time is also smart and just prudent. I think we probably should shift our focus from avoiding waste a little bit. I really think the focus needs to be on patient safety, and we have to accept a certain amount of waste if we're going to do that. Some of the regional blood centers will work with you on kind of rotating your stock. So if you can have a couple units of blood in, or all 6 of them, for a few weeks, and then rotate them out for some that are a little bit fresher, and they can send them to hospitals that have a higher turnover, so that you have those blood units on hand, but they're not going all the way to their out date. So you might have to do a little arm twisting for that, but I think that's possible and it's doable.
Okay. Thank you, Dr. Mason, so much for spending time with us today and presenting this valuable information. I know I have a page full of notes here just from listening to you, and some great ideas to share with others that are involved in the partnership.
Great.
Oh, look, there's one more question. When developing your protocol, what time parameters were looked at and why a designated shelf?
What time parameters? I'm not sure what's meant by that, and why a designated shelf. So I'll take a swing at what you mean by why a designated shelf. So we after we do our pre-issuing, we put it in a certain spot so that we always know exactly where to go quickly to get it, and we don't accidentally pull those units of blood to be issued to another patient. So if we just put them back in routine inventory, and then a routine order of blood came in and we took one of those units, cross-matched it, and sent it out, now we're short a unit in our pack. So we want to have our trauma pack be separate so that we know that that's designated for that thing. We actually do rotate that, so if we haven't had a massive transfusion in a while, we make sure that that blood gets put back out into inventory so it does get used, and we put fresher blood in there so that we don't end up expiring anything that's there. So the time frames, I think we're just faster is better. So we were always kind of focused on how can we get this process through quicker. So having the pre-thawed plasma was one strategy. Having the checks before the massive transfusion protocol was even asked for sped that process up significantly. I hope I answered that.
She followed that up with and said, how quickly delivered to the unit or patient? Any mock run?
Okay, so our goal is to have the blood to the patient's bedside in under 10 minutes. We usually are more like 5 minutes. We do time ourselves. We do audit that. Every time we do a massive transfusion, and we always have somebody running from the blood bank to the location with the cooler. The locations, most of the locations who are likely to have massive bleeding already have refrigerators out there, so they've already started with their first unit or two of uncross-matched blood by the time we've arrived there with the cooler. So with that situation, it's pretty much instantaneous, because they've already got some cross-matched blood right there where they're at, and then we're bringing more by the time that they're ready to use more. But it is going to be really dependent on your situation. If you only have one person in the blood bank, you can't have that person running to where you are, because then there's nobody preparing the next round for you. So it might need to be somebody from OB running to the blood bank and getting it, and how fast could that happen? So, and if it's unacceptably high, then other strategies like having a refrigerator where you're at, or having coolers on standby is a thought.
Great ideas. That will be very helpful to our smaller hospitals as they try to maneuver that. That was an issue they raised, that only one person was at the blood bank when they had emergency.
Yeah, so. Yeah, and that's, I know where I was before at Harbor, we did not have a big enough staff to run somebody from the blood bank to the labor and delivery, so we needed to have somebody come from there to us. Here at Cedars, we have a little bit more luxury there, and so we have enough staff that we can run somebody out.
Well, great. Well, again, thank you so much, Dr. Mason, for sharing your time with us today and providing such great information and strategies to maximize the relationship with our blood bank to provide patient care that is the safest we can. Again, I just want to remind folks that this has been recorded, and we will make it available on our CMQCC website. I think there were some very valuable pearls that we learned today. I encourage you to share it with your blood bank if they weren't able to be on the call, and really start that discussion with them if you haven't already. Again, regarding the continuing ed units, we will have an answer soon and let you know as far as being able to collect 1 CE for attendance today. If you have any questions, feel free to email either myself or Valerie Cape, and we will connect you with the answers that you need, whether we can contact Dr. Mason and have her answer you directly, or perhaps we can use some alternate methods. But thank you for joining us today, and enjoy the rest of your day. Thank you so much.
Thank you.
Thanks, Holly.
Thanks.
Bye.
Bye.